Okay, once again, good morning, everyone. This is a new grand rounds for today. We had a very special guest today. It's Dr. Sandroni. She is a professor of neurology at Mayo Clinic in Rochester. She graduated from Milan Medical School and subsequently moved to the US for additional research and clinical training. She joined into the staff at Mayo after completing a residency in neurology, fellowship in peripheral nerve disorders, and a pain medicine scholarship. She's certified in neuromuscular disorders, autonomic disorders, and pain medicine besides neurology. She's a division chair of the autonomic section at Mayo and chair of neurology in Mayo Health System Hospital in Mankato. She teaches regularly at AN and lectures all over the world, and she has a very prolific author and had over like 150 peer-reviewed papers, books, and multiple book chapters. So we welcome Dr. Sandroni. Thank you so much for accepting this invitation. And now you have the microphone and spotlight.
Good morning, everybody, and thank you so much for inviting me. Can you see my screen?
Yes, we can.
Good. So today we're going to talk about autonomic disorder, and I'm very happy that you guys invited me because I realize that there are very few autonomic specialists, and so although these are very common conditions, you may not get exposed to it enough, and we have a huge need of specialists on this. So let's see. All right, so I have nothing to disclose. So first thing to remember is the autonomic symptoms are really common, and doesn't mean that there is an autonomic disorder. The autonomic system plays a key role to maintain the body homeostasis, modulate immune responses. It's our own stress response mechanism. And so the presence of autonomic symptoms doesn't necessarily mean that there is an autonomic disorder, but simply imply that the system is activated and fighting and sometimes malfunction while doing so, or the response is maladaptive because of something else that's going on. Like everything in neurology, you have to have the same question when you have an autonomic symptoms. Is this an autonomic problem, or is this, again, an epiphenomenon of something else? The answer sometimes is the most difficult one to answer to. And make sure that you rule out systemic condition that could explain the patient's symptoms, particularly condition affecting the cardiovascular and the gastrointestinal system. Think, for instance, about congestive heart failure. Those patients will have a very high sympathetic tone. That doesn't mean that there is an autonomic problem. It's, again, it's a stress response, an adaptive response to the patient's situation. And also, sometimes patient presents with more than one condition. So you have to sort things out and peel the patient like an onion, one layer at a time, and see what you can find out. How to obtain an autonomic history? You have to go system by system. The most common symptoms that we encounter, I would say, are attributable to the cardiovascular system. So symptoms of orthostatic hypotension, orthostatic intolerance, and syncope are definitely our most common reason for referral. Then we have gastrointestinal symptoms, gastroparesis, constipation, much more so than accelerated transit, such as dumping syndrome or diarrhea. Genitourinary symptoms include a neurogenic bladder and sexual dysfunction. And then you needed to question the patient regarding secretomotor system, which basically refers to the impairment of production of tears, saliva, and sweat. Most patients can identify if they have a Zika type symptom, but not very many patients are very in tune with how much they actually sweat. So you have patients that may complain they sweat too much or too little, and then when you test them, they're actually normal. So usually I ask more how they can tolerate heat and how they tolerate cold. Following the next set of questions, you have to look at the temporal profile. That's a clue into possible etiology. If you have an acute onset, usually you have an inflammatory condition or a toxic exposure or an acute metabolic derangement. Subacute generally is metabolic or autoimmune, and chronic we're dealing with degenerative syndromes, and again, still metabolic, you can never exclude it. Then you have to look at the distribution. Is the process focal? Think about conditions such as Harlequin syndrome, palmoplantar hyperhidrosis, AD's pupil, or complex regional pain syndrome, and autonomic cephalalgias. Does the problem affect only one system? You could have limited cholinergic autonomic neuropathies, such as chronic idiopathic anhidrosis. And then you may have idiopathic orthostatic hypotension in isolation from anything else. And then another very unique condition is an isolated enteric neuropathy. The enteric nervous system is literally a second brain and works almost as a separate entity in many ways. So you may have conditions that affect only the enteric nervous system without affecting any other autonomic or neurologic system. And then the question is, what if the process is more generalized? Usually we're dealing with autonomic ganglionopathies and then conditions such as pure autonomic failure and multiple system atrophy. Just to put the picture in, just to break it a little, here an example of palmoplantar hyperhidrosis. The patient is dusted with a powder that contains alizarin red, which is yellowish when it's dry and turns purple when it's wet. We'll talk about the test a little bit later, but this is an example of a patient that had very prominent excessive sweating. So how do we evaluate this patient? First of all, as I said, you need to rule out other causes. So in terms of lab testing, you do the usual comprehensive metabolic panel, you look at autoimmune panel, and depending upon the situation, you may go also with spinal fluid analysis. Then we do the autonomic testing, which have three main domains that we look at: pseudomotor function, and we do it, the periphery is done with a QSART system on the Q-sweat, and then we have a thermoregulatory sweat test. Then you look at cardiovagal responses by assessing responses to heart rate, to the breathing, and the Valsalva maneuver. And the cardiovascular testing is obtained by monitoring beat-to-beat blood pressure and heart rate while the patient performs the Valsalva maneuver and the tilt. Depending upon the situation, you may want a more specific cardiac evaluation with a HECO, Holter, stress test, whatever is deemed appropriate. In terms of gastrointestinal and genitourinary study, again, if the patient has significant symptoms at that level, we usually proceed with a gastrointestinal transit, gastric accommodation study, urodynamic studies, and oftentimes anorectal manometry, because we're detecting more and more pelvic floor dysfunction that are labeled as GI dysmotility, and the treatment is obviously very different. In terms of imaging, if you think about the central autonomic disorder, we can do obviously MRIs and functional studies such as PET scan, and various biopsies depending upon what your index of suspicion: skin biopsy for epidermal nerve fiber and synuclein deposit, fat aspirate for amyloid, lip biopsy if you think something like Sjogren's syndrome. So let's go and talk about autonomic peripheral neuropathies. There are many forms, so I'm going to talk only about the three most common ones that you definitely cannot afford to miss. The other ones, again, are rarer, and the degree of involvement may not be actually as dramatic. Diabetic autonomic neuropathy is definitely the most common one you will encounter, simply because diabetes is incredibly common and prevalent. The number of patients with diabetes that develop peripheral neuropathy and autonomic neuropathy varies depending upon the severity of the diabetes, the duration of diabetes, and depending also which studies you look at. These were still old studies, and there isn't anything probably much better than that still. So probably about 50% roughly of patients with diabetes eventually will develop some symptoms of neuropathy and autonomic dysfunction. This was a landmark paper that showed that patients with autonomic cardiovascular neuropathy in diabetes have a much higher morbidity and mortality, particularly if I also have a nephropathy, but is also an independent factor. So even by itself, in absence of the nephropathy, portend a much poorer prognosis. So something to keep in mind. And the first thing that we usually see in this patient is the loss of cardiovagal function. So patient lose the modulation of heart rate variability. So the prevalence of cardiac autonomic neuropathy is around 20% and increases up to 65% with age and diabetes duration. Established risk factors are glycemic control in the type 1 diabetes and a combination of this metabolic syndrome in the type 2 diabetes. It's a great risk marker for mortality and cardiovascular morbidity, as I mentioned, and possibly a progression promoter of the diabetic nephropathy. But the two basically are synergistic in creating more problems. Another form of diabetic neuropathy that you should be on the lookout for is the treatment-induced neuropathy. It used to be called insulin neuritis and was first reported almost 100 years ago. And the recent reports have been described that doesn't happen only when people are treated with insulin, but can actually be also with other hypoglycemic agents, such as oral hypoglycemic agent. Usually the patient starts with a very high hemoglobin A1C, maybe a brand new patient that wasn't aware that was diabetic, and the glycemic control is rapid, and in fact too rapid, and that's what caused this condition. The mechanism, there is a cytokine release and a relative hypoglycemia that results in axonal transport failure. The patient generally presents with a significant autonomic symptoms, abnormality in the testing, severe pain, and loss of intraepidermal nerve fiber density. And the symptoms, thankfully, improve over time, but it's something that you need really to be aware of. These were from a study that Dr. Gibbons did. So the more rapid the correction, the worse the manifestation of the patient presentation. So the recommendation is to correct the hemoglobin A1C no faster than dropping by 2 points over a period of 3 months. The next neuropathy that you needed to be on the lookout for, particularly now, I would say, because we have more treatment options than we ever had in the past, is the amyloid neuropathy. Amyloid is not per se a toxic protein. It's a misfolded protein with glycosaminoglycans. And what's normally an alpha helical configuration results in forming a beta pleated sheet and accumulates in the extracellular space of tissues and organs. So although it's not toxic by itself, it really interferes with the normal function of the tissue where it's deposited. And stains selectively with Congo red, like here, the methyl violet, and with immunostains, and on the bipolarized light has an apple green birefringence. That makes it quite pretty, but again, is not a good condition to have. There are various forms of amyloidosis, and the most common is the primary amyloidosis. There are probably around 2,000 to 3,000 cases annually in the US, but the number is fluid. It's a plasma cell proliferative disorder. It's a clonal population of bone marrow cells that produces kappa or lambda monoclonal immunoglobulin light chains or light chains fragments. Symptoms usually appears in the 6th or 7th decade. Things that should alert you to this condition is presence of unexplained weight loss, fatigue. The patient will present with peripheral neuropathy that can actually be the presenting feature or could be an incidental finding if the patient already knows that they have a monoclonal protein. And the autonomic involvement is almost universal at some point in their disease and presents with cardiovascular, gastrointestinal, urogenital symptoms. And it is present in 65% of the patient with already peripheral neuropathy. Other symptoms that the patient may have that should raise your antennas and think about this is presence of an enlarged tongue, easy bruisability, and hepatomegaly. The median survival ranges from 13 to 35 months. 3-year survival, 38 to 50%, although these numbers are improving as the detection is done sooner and sooner, and treatment, particularly with bone marrow transplant, has definitely become much more sophisticated and much more effective. The prognosis for the patient with an autonomic neuropathy and cardiac disease, particularly if they have heart failure, is much, much, much worse. The treatment, as I already alluded, is with high-dose chemotherapy and autologous stem cell transplant. Of course, you cannot do it on everybody. These are patients who should be very carefully selected. Otherwise, the morbidity and the mortality from the treatment itself is too high to be acceptable. And treatment protocols include various agents as listed, including dexamethasone, cytoxan, melphalan, bortezomib, lenalidomide, and thalidomide in various combinations. Next, I'd like to talk about familial amyloid polyneuropathy. It is an autosomal dominantly inherited disease group. The amyloid precursor, again, is a mutant protein, and the most common one is a mutant transthyretin. And there are over 100 documented mutations. And there are mutations that occur in genes for other proteins, particularly lipoprotein A1 and A2, fibrinogen, lysozyme, and gelsolin. Gelsolin actually causes a very unique amyloid neuropathy, which is much more benign, but it creates very unique facial features, and it's pretty much limited to the Finnish community. Incredibly rare. I don't think you'll ever see one of those. But you're definitely going to see amyloid due to familial forms. These are the distributions map, really, of the transthyretin mutation. And you may not be surprised that it seems to follow particularly the coastline, and this because the genes seem to have originated from Portugal, and they were obviously very successful sailors, and they spread the happiness throughout the planet. Typically, the most atypical form, I should say, presents in the 3rd to the 5th decade with a prominent autonomic symptomatology, painful sensory motor neuropathy, carpal tunnel syndrome, and you should really be on the lookout for that, particularly if you have a young person with bilateral carpal tunnel, vitreous opacity, and then other organ involvement, particularly at the gut level, the kidney, and the heart. Death occurs within 5 to 15 years from the time of the appearance of the symptoms. And the most mutated amyloidogenic TTR is secreted by the liver. So for many years, orthotopic liver transplant was considered a surgical gene therapy, significantly decreases circulating mutated TTR and improves the survival with a 5-year survival of 80% after liver transplant, and improves the overall symptomatology, but does not really completely arrest the progression of the disease. And after a few years also, the liver pretty much will fail. But this was pretty much the idea. You eliminate the source of the liver that generates the mutated TTR. And then another way to really try to correct this syndrome is now with the antisense oligonucleotides and small interfering RNA medication that have completely changed the behavior and the natural history of these conditions. Again, the problem is that these proteins are abnormal in a way that misfolds and aggregate, and then they deposit, and that's where they cause trouble. There are other targets to prevent the dissociation and misfolding. So those are medications such as diflunisal and tafamidis. And there are other medications such as doxycycline and TUDCA that will try to reduce the deposition of the protein in the end organs. And there are some clearance molecules that are in development to try to remove the already deposited amyloid, and that seems to be a little tricky to do. Depends also how much amyloid has been deposited already. So treatment strategies, again, diflunisal was the first one that was used. Doesn't work spectacularly. Tafamidis now is approved for the cardiomyopathy. It's another stabilizer. Seems to be working quite well in reducing cardiac hospitalization and morbidity about 30%. From a neuropathy standpoint, both inotersen and patisiran have shown incredible results. They are gene silencing, siRNA and antisense oligonucleotides that reduce deposition and facilitate antibody-mediated clearance. If you start this early enough, you may reverse some of the neuropathy deficits, and otherwise they're both quite effective. One is sub-Q, the other is an IV. They both have their plus and minuses in terms of risks and side effects, but overall, this has been fantastic. For many years, this was a death sentence, and now this is changing the scenes for this. So the messages I would like to have for that is test the patient for these forms. I think we have an underestimation at this time of how many patients are carrier, because now we have finally disease-modifying therapy. Testing the patient and recognizing the carrier is very important. We have many families that we're following, and as soon as they start to develop symptoms or we have evidence of some deposition of amyloid, then when we start treatment. We don't start in a preclinical stage. First of all, the medication are way too expensive, and there is no evidence that really will provide additional value and will add costs and risks. And the other thing is, as I was mentioning before, there are over 100 mutations, and there are some pockets of mutations. Some are more common than others. The MET-Val30 is definitely the most common one, but there are many others, and the onset varies dramatically from one gene mutation to the other. So there are some forms that won't manifest until patient is in their 50s or 60s. So there is no reason to start treatment when they are in their 20s. And the best prognosis, the best indicator of when they will start is if they have another family member affected when the family member started to have symptoms. Okay, moving on, we're going to talk about the autonomic ganglionopathy. See this basically as the Guillain-Barré equivalent of the autonomic nervous system. Typically affects young or middle-aged, previously healthy individual. Patient can present with severe autonomic failure, indeed used to be called pandysautonomia, with a peak severity within days to weeks. There is a female to male ratio of 2:1. Usually the course is monophasic with a slow spontaneous recovery. In about 2/3, patient may identify a preceding event, such as a viral syndrome, a immunization, or even an elective procedure. Some viruses seems to have a higher probability of causing this. I would say the Epstein-Barr is probably the one that we've seen the most. Only 1/3 of the patient will have, however, a full complete recovery. 2/3 will have incomplete recovery, particularly symptoms of erectile dysfunction. That will be the most difficult one to recover completely. And sometimes sweat loss is the last one. The antibody is an antibody that blocks the M3 cholinergic receptor and cause autonomic dysfunction at the ganglia level. The serum level of the antibody correlates with the severity of the autonomic dysfunction, and with higher level, usually you have more widespread and more severe autonomic failure. This is not the only autonomic neuropathy that's immune-mediated. There are many others. First of all, you can see autonomic involvement in the more traditional Guillain-Barré syndrome. And then you can have the paraneoplastic channelopathies. The anti-HU are the most common, with about 30% having autonomic abnormalities. but also all the others like PQ and MDA definitely can cause autonomic instability and actually dysreflexia if you also have the encephalitis. Potassium channel, amphiphysin, etc., all can cause autonomic neuropathy. The potassium channel can cause Morvan syndrome with encephalopathy, myokymia, pain, orthostatic hypotension, tachycardia, hyperhidrosis, etc. The NMDA form, as you well know, will cause encephalitis and autonomic instability with hyperthermia, tachycardia, hypersalivation, hypertension, or vice versa, bradycardia and hypotension, urinary incontinence, and erectile dysfunction. The sodium channelopathies can generally cause a Zika complex, can reduce urinary sensation, various symptoms of orthostatic intolerance, altered sweating, and alternating constipation and diarrhea. Acute GI dysmotility can occur with a certain specific antibody listed there, specifically the alpha-3 acetylcholine receptor or alpha-1 acetylcholine receptor, the PCA2, the DPX, NIF, GFAP, etc., and the voltage-gated calcium and LGI1 and Casper2 antibody. And then, of course, you may have autoimmune symptoms in other autoimmune disorder, particularly Sjogren. Sjogren, besides the obvious Zika manifestation, can have a more diffuse autonomic ganglionopathy that can be severe. And also variably lupus and celiac can cause a similar condition to some extent. Let me talk a minute about treatment for this. For the autoimmune form, definitely you need to use immunomodulation therapy. Unfortunately, because of the relative rarity of this syndrome and the fact that treatment was already available, every attempt that has been done to try to have a randomized trial has failed. But generally, we recommend intravenous immunoglobulin or plasma exchange. And then if the patient requires long-term treatment, try to convert it to an oral immunosuppressive agent. If the patient is refractory, consider rituximab. In terms of symptomatic treatment for the orthostatic hypotension, midodrine, Florinef, pyridostigmine, droxidopa, if necessary, compression garments, and the usual non-pharmacological strategies, fluid, salt, etc. And for the gastrointestinal and genitourinary symptoms, the patient may, depending upon the situation, require various treatment with laxative. Some of them, particularly in the acute stage, may require a feeding tube and catheterization that eventually, as the patient improves, they can be transitioned out. Let's move on now to talk about central autonomic disorder. This is obviously a very broad spectrum. You can have various central autonomic manifestations due to, for instance, to conditions such as serotonin syndrome, the opioid or neuroleptic syndrome, illicit drug syndromes. And you may see autonomic dysreflexia in a patient that have cord lesion above T6, patient with hypothalamic lesions, severe traumatic brain injuries, encephalitis, and in patient with baroreceptor failure. Now, this is a growing group because in the past, these patients with very extensive neck dissection due to cancer, extensive radiation, etc., didn't live long enough. Now they do, but they will experience a problem of very difficult to control blood pressure and heart rate because they lose the baroreceptor function. So again, these are not patients that are rare to see these days, and they're very difficult to manage. So hopefully you'll learn about that. So the focus, however, that I want to talk about are the synucleinopathies, which are the most typical central autonomic disorder by definition. And it's a family of disease, all characterized by the position of synuclein. The most severe and the most polysymptomatic form is multiple system atrophy that presents with autonomic failure and a form of extrapyramidal motor dysfunction, either in terms of Parkinsonism or cerebellar ataxia. As the disease progresses, the patient will develop both eventually. Then the next level would be with diffuse Lewy body disease. The difference is that the patient will have some dementia, while patient with MSA almost never have any cognitive impairment. The Parkinsonism, the hallucination, REM behavior disorder is present throughout all of them. And the autonomic dysfunction is less severe than multiple system atrophy. They literally position themselves between Parkinson and MSA. Parkinson's disease as a group has the least severe autonomic involvement. However, it's also the most common condition. And because there is always a spectrum, some patients might have autonomic involvement that can be a little bit more problematic than others. They may have some dementia, and of course, they are the ones that respond to levodopa the best. While Lewy body and MSA, patient might respond transiently to levodopa, but the response is never as good as in idiopathic Parkinson and is not long-lasting. And then we have pure autonomic failure, where it's there is nothing else except the pure autonomic dysfunction. See it as the equivalent of ALS in the motor system. This is equivalent in the autonomic system. However, having said that, there is a group of these patients, they may evolve over time into MSA, and we will talk about that. Hallmark, presence of Lewy body and glial cytoplasmic inclusions. Consensus criteria, which has now been criticized, but anyway, pretty much the concept is you need to diagnose multiple system atrophy. You need to have significant autonomic failure defined as orthostatic blood pressure drop or severe neurogenic bladder, or both. Poorly Doppler responsive Parkinsonism. Tremor is actually relatively rare in MSA. It's really more a rigid syndrome. And then you may have a cerebellar dysfunction. Definitely, really, it's only at this point with autopsy, although we are reaching more biomarkers that will allow us to create a more definite diagnosis when the patient is still alive. And probable MSA is you have autonomic failure and the P form, Parkinsonism, or the cerebellar ataxia. Possible is when the patient is very early, sometimes it's impossible to differentiate, and you just need to follow the patient over time. If the patient does not fulfill the criteria today, see them back in 6 to 12 months, and usually they will. These are the central autonomic network. Again, very complex set of structures that goes from the sacral region that controls all the micturition, defecation, and erection reflexes to the intermediate cell lateral column in the spine that controls all the autonomic reflex for circulation, respiration, micturition, gastrointestinal symptoms. And the brainstem controls most of these function, again, with control of blood pressure, respiratory control. This is where the problem starts when you lose the, for instance, the control in multiple system atrophy, so and synucleinopathy. So they lose the paralysis during REM sleep that manifests as the REM behavior disorder. And that's why also patients may die in their sleep because they develop central hypoventilation with this syndrome. The higher centers are really more integration of autonomic function, arousal, pain modulation, motivation, stress responsive, interoceptive awareness, and so forth. So very complex. Any pathology at any level will result in some dysfunction of the system, although the system is thankfully redundant, and so usually just one lesion won't be so devastating. There is a different level of involvement of these central structures in the synucleinopathies. And in multiple system atrophy, the brunt of the pathology is really on the central forms and much less in Parkinson and diffuse Lewy body disease. And none of these structures is affected in pure autonomic failure. Note that in Parkinson disease and diffuse Lewy body, the dorsal nucleus, motor nucleus of the vagus is very heavily involved. And that's why patients with Parkinson and diffuse Lewy body disease may present with constipation many years, even before they develop the motor manifestations. At the peripheral level, depending upon, of course, of what stage the patient is, but the Parkinson disease and pure autonomic failure patient have much more severe involvement of the ganglion and the peripheral structures, while those are minimally, if ever, affected in multiple system atrophy. Now, I said that some patients with pure autonomic failure may actually evolve into multiple system atrophy. This was the first study that we did. Dr. Singer was a lead author a few years ago. And we looked at risk of converting. And the biggest factor seems to be to have evidence of severe bladder dysfunction and presence of high supine norepinephrine. In pure autonomic failure, supine norepinephrine most of the time is below 100. So if we suspected pure autonomic failure, and if clinically the patient was pure autonomic failure, but the supine norepinephrine was higher, there was a very high rate of conversion to multiple system atrophy. And then more recent study done by Dr. Kuhn in our group, again, confirmed most of these features with preganglionic sweat loss on the sweat test, subtle motor sign. And again, keep in mind, sometimes you have older patients and they may develop a little bit of slowness as part of a paraphysiologic component of aging. So you're not always 100% sure, but if you have any subtle motor signs, the risk of phenoconversion is definitely higher. And you see also all the other parameters. And again, with a supine norepinephrine level being significant, a more severe degree of autonomic impairment also was a predictor of conversion. In terms of phenoconversion from PAF to Parkinson's disease and diffuse Lewy body dementia, the biggest thing was truly the subtle motor sign and presentation, green and empty behavior, constipation, and age of onset. This is an example of a patient with multiple system atrophy that has had this for quite some time. This is a TILT study. In red, we have the systolic. In yellow, the diastolic blood pressure, and green is the heart rate. And here you notice the classic profile of this patient. The blood pressure drops, then they plateau. There is no cardiac responses, but the patient doesn't faint. Why? Because they compensate by generating supine hypertension. So don't be too excited if this patient has supine hypertension. I get nervous if they go above 200, but don't treat them too aggressively, otherwise they will crash to the ground. So the biggest thing is avoid the supine hypertension. We'll talk about that in a minute, but basically just simply having them elevate the head of the bed is sufficient in most cases. Now, this is a natural image of a patient with multiple system atrophy that just completed the sweat test. The sweat test is a very interesting test, and only few places have the capability of doing this because it's a very expensive equipment, very messy, but it's really a very cool test. The patient is dusted with the alizarin red powder that I mentioned before. That's dry when it's, it's yellow when it's dry and turn purple when it's wet. Then the patient is placed into a cabinet where we have a temperature at about 110 and about 40% humidity. And we monitor skin temperature and core temperature through an oral thermometer. And we want to see if they are able to sweat. We like to reach a core temperature of 38 degrees Celsius or 1 degree above their baseline, whichever is the highest. Of course, if they sweat normally, they're taken out at that point. And this is a classic pattern that we recognize, and actually we published about, in patients with multiple system atrophy. They have preserved sweating in the hands and the feet, and they don't have sweating in the rest of the body. This is exactly the opposite of what happened if you think of a patient with peripheral neuropathy. They have a glove stocking distribution, loss of function. Here is completely the opposite. And it's so unique that we call it if we see it. In terms of treatment, there are some trials ongoing, I should say, particularly with stem cells, and there will be antibody trials, no different than what people are doing with Alzheimer's disease, really. But for the moment, what we have available is really symptomatic treatment. Levodopa therapy, as mentioned, the response usually is partial and transient and may worsen the orthostatic hypotension. Then we need to work on anti-orthostatic hypotension strategies. Fluid, salt, keep the patient active, compressive garments, sleep with the head of the bed elevated, and the medication that I mentioned before. You need to treat the neurogenic bladder and bowel. And that can be quite involved, particularly as the patient progresses. Most of them eventually end up with an indwelling catheter. Patient needs to have a sleep study done. If they have stridor, the patient needs a tracheostomy, or they will die in their sleep. Management of REM behavior disorder is with melatonin and clonazepam. Very important to have physiotherapy, nutritional therapy, speech therapy to help with the communication, because of course they develop pretty significant dysarthria as well as the dysphagia. And we have now implemented a MSA clinic that's modeled very much like the ALS clinic, and we have a palliative care involved earlier in the course of their disease, and the patient and family have been very pleased with that type of intervention we're doing. In terms of the orthostatic hypotension management, if you like acronyms, you can go with the older paper by Dr. Figueroa. And this is pretty much what we're saying before. So compressive garment, water treatment. This is an interesting strategy. If the patient gulps 2 cups of cold water, and it has to be water, not tea, no Gatorade, and no nothing else, the blood pressure will rise within 10-15 minutes and will stay up for almost an hour. It's a duodenal reflex. And so that can be a very useful trick if the patient needs to go and run an errand, for instance. Sleeping with the head of the bed elevated, learning physical counter maneuvers that basically are strategies to force the patient to perform isometric tension of their muscles that will raise the blood pressure transiently, but will buy them some time. These are the medication that we have available. Atomoxetine was promising, but the most recent trial actually didn't show statistical significance. So may still be an option in some patients, but you're going to have a pretty good fight with the insurance to cover it. Make sure the patient understands what their first signs of the blood pressure is dropping. Some patients are very well aware of it, others aren't, and those are the ones that get in trouble because then they faint and they injure themselves. And again, increase fluid and salt. Remember that if you use fluorine F, you need to monitor salt and potassium levels. How to manage supine hypertension? Reduce the fluorine F if the patient is on it. Elevated head of the bed. A nightcap can be very helpful because obviously alcohol is a vasodilator, so we'll reduce that. Or use medication that are short-acting, and the patient will take them at night before going to bed, and by morning the the efficacy should have worn off, so they should be okay to go for their day. Now, in the last few minutes, I would like to talk about the dysfunctional syndromes, and which include the postural tachycardia syndrome, irritable bowel and functional dyspepsia, interstitial cystitis, chronic fatigue. They often coexist. It's unclear how much true autonomic abnormality is primary or secondary. These are not disorders, these are syndromes, so are very heterogeneous and can be secondary to something else. Orthostatic intolerance is the reduced capacity to tolerate erect posture due to POTS, orthostatic hypotension, and syncope. Again, there is an overlap in some of these forms, but others can be totally in isolation. These are extremely common syndromes. Not everyone has the same symptoms, as I said. Most symptoms can be attributed to alteration in the way the autonomic system is working. So basically more like a maladaptive response or a persistent response that's not now necessary anymore. This is what patients with postural tachycardia syndrome would present with most of the time. They will drown you with 65 different complaints. Usually are younger women, and this can be very debilitating, obviously impact our functional capacity and quality of life significantly, but is actually manageable. The definition traditionally was to have at least 30 beats per minute increment, 40 in children and teenager, as well as symptoms of hypoperfusion and symptoms of sympathetic activation. We used to say that we needed to reach at least 120 or 130 beat per minute in adult and children respectively. Now we kind of leave that a little bit looser. These patients, as mentioned, almost always have a lot of other symptoms. While the syncope patient, usually, unless they have a recurrent syncope, they are monosymptomatic and they found that much less disabling. This is what a heart rate and blood pressure profile will look like in a patient with postural tachycardia syndrome. Again, they don't faint, but they feel like they could. And actually, if you keep them up long enough, they will eventually faint. It's just that they feel uncomfortable because this patient, for instance, was just simply standing there. Heart rate went up to 140. I'd get 140 if I'm running, but there is no reason for me to get 140 if I'm just simply standing. And so the body perceives that as something that's not okay. There are maybe other conditions associated with postural tachycardia syndrome. This was a study that was done by their own group and was self-reported, so take it with a grain of salt. However, we may see some other autoimmune condition. Mast cell activation disorder is way overdiagnosed. It's really an extremely rare condition. Anxiety hypervigilance is definitely very high, and the conditioning is very high. Almost always these patients have type A personality. So use that to your advantage. Make sure to rule out the secondary forms. So you may still need to rule out a cardiac pathology, thyroid disease. Patient with a CSF leak may present with a POTS-like manifestation. And there could be some autoimmune syndrome that cause this, particularly when you have a patient that developed this after an acute illness. There are a lot of antibodies that have been reported, but it's unclear how many are truly pathogenic. Empower the patients. Again, these are type A personalities, so use that to your advantage. Educate them, and they can do a lot with just non-pharmacological strategies. Lifestyle modification, exercise. If necessary, you can use a dual effect agent that modulate anxiety and vasomotor symptoms and sometimes pain, such as an SNRI, or a drug that I like a lot these days is mirtazapine. And before I close, I would like to let you know that we have an Autonomic Disorder Fellowship. It's a UCNS accredited fellowship with a clinical assessment, management. You learn about autonomic testing, you learn about how to interpret, plenty of research opportunities in elective time. This is the web link. And I used to be the fellowship director. Now is Dr. Kuhn, who is a very talented and enthusiastic person. And that's her comment. It will be the best year of your life. And with that, I am done.
Thank you so much, Dr. Sandroni. That was a very wonderful lecture. So now we have time for some questions. There is already one in the chat. And the question is, what is the survival rate of autoimmune autonomic ganglionopathy if we compare it with GBS?
Autonomic ganglionopathy do not have any issue in terms of survival. They may be uncomfortable, they may have impairment in quality of life, but no, there is no death associated with it. So much better than Guillain-Barré. Of course, if you have it though in a setting of Guillain-Barré, then the prognosis for the Guillain-Barré component is worse because they may have also more central dysregulation as well, and the management generally is much more difficult.
Okay. And the microphone is open if there is any questions. We can barely hear the question.
Yeah, good morning. This is Nick Paumitsakis. Thank you very much for the nice lecture, very comprehensive. I have just a simple question, maybe educational also for our residents. How do you check for orthostasis? Because some people use lying, sitting, standing positions. They wait for 1 minute or 3 minutes. Can you just tell us how do you approach this and to confirm that somebody has orthostasis as a first screening tool?
Yes, at bedside, the thing you can do is I usually start supine. Would be ideal if the patient can lay down for a few minutes. So check the pressure supine, then check it sitting. If I think the patient truly has orthostatic hypotension, I check it sitting. Otherwise, I just have them stand and I measure it right away, which usually it's between 30 seconds and 1 minute, and then I wait 3 minutes. If the patient has already had multiple syncope or they become lightheaded very quickly, I check it when they sit up. It's significant if you drop at least 20 millimeter of mercury systolic or 10 diastolic. Now, what I didn't mention is the fact that patient will report dizziness, lightheadedness, numbness, whatever, in a way, I mean, they use those words very different than the way we use it. And we're picking up also a lot of patients that are referred thinking that they have, let's say, postural tachycardia syndrome or orthostatic hypotension. And they're very dizzy when they stand, but their hemodynamic profile is very stable. Those are probably patients that have persistent postural perceptual dizziness, which is, again, a form of central sensitization. There is a big overlap between the vestibular pathways and the autonomic pathways. And I think there is a number in the current practice of neurology that's coming out. Dr. Bogle, his first author from Arizona, put a nice article putting all this together. So the treatment, that's why it's very important to test this patient. Don't assume because the patient says, I'm lightheaded, that actually they have a drop in blood pressure. If they have persistent postural, perceptual dizziness, they need vestibular rehab. They don't need medication to change their blood pressure.
Thank you.
Yes, could I just ask a question, Dr. Hanziska? You mentioned 4 cortical and subcortical structures and 4 brainstem structures in the anatomy of the autonomic nervous system.
Yes.
Are there pathways connecting them separate for the sympathetic and parasympathetic, or exactly what is going on above the spinal cord?
Oh, well, there are certain structures in the brainstem that are purely sympathetic and others are purely parasympathetic. I don't know if I can go back to the image, but the higher level, there is integration. So at the amygdala, the orbital frontals, the insular cortex, there is a big overlap and there is integration at that level. But then there are structures that are predominantly parasympathetic and others that are predominantly sympathetic at the brainstem level. But obviously they integrate with each other, particularly if you think about, again, I was talking about the nuclear motor dorsalis nucleus of vagus. That's clearly a parasympathetic structure, but will interact with all the other noradrenergic structures at the brainstem. In the spine level, the intermediate lateral column is the sympathetic structures, and the parasympathetic structures are in the sacral and in the higher cervical region. But obviously, it's always a balance. I mean, those, again, you cannot have one without the others. They always work together. There are some functions that are predominantly dominated by the cholinergic and parasympathetic system, or even if you think about sweat, is sympathetic but cholinergic. So, but then there are other systems, particularly, let's say, sexual function, that's clearly you have to have both working together.
Okay.
Thank you, Dr. Sandroni, for the wonderful lecture. I have a question. So nowadays, during COVID era, we're learning more about autonomic dysfunction, maybe as a manifestation of long-haul COVID. So do you think there is an actual correlation between these two, and or is it more deconditioning? And if there is a correlation, do you think there is preventive measures we should take, or what should we do?
Very good question. Nice to see you, by the way, Dima.
Nice to see you too.
We had created a COVID clinic, like everyone else, thinking about this long COVID, post-COVID autonomic instability. We found actually much less than we thought we were going to find. And I totally agree that probably 90% of the one we have seen are more because they were deconditioned. People were more stressed out. You couldn't go out. They couldn't exercise. So I think it was more a secondary form. We have also seen plenty of patients, and those were the ones, though, that we also saw in the hospital with the encephalitis or with the Guillain-Barré as part of COVID, that will have more issues. I just saw a patient the other day. This patient develop more respiratory symptoms. So now, yes, if I test them, they're going to be a little abnormal, but I think it's secondary. I don't think it's a primary event yet. But the jury's still out. I don't think we have enough number. We had our annual meeting a couple of weeks ago, and the group from Milan, because of course they had the big onslaught of COVID first, they had a few more cases with autonomic instability. But I think it's by no means as common as people had anticipated, at least as a primary process.
Thank you.
Dr. Sandroni, there is a question from the chat. It's mentioned that about the supine hypertension treatments do have any effects on postural hypertension, like bring it about?
Yeah, that's why I said if I could avoid, sometimes we can avoid any medication, just simply elevating the head of the bed, but sometimes still this patient can have very high blood pressure when they are supine. And so you needed to use a medication such as low-dose losartan or nitroglycerin patch, something that's short-acting. So by morning, the effect has worn off, or like in case of nitroglycerin, they take it off. But yes, it's we have to really balance it very closely, and sometimes we have to ask our primary care colleagues, please don't treat the hypertension in this patient, allow them to have a little bit more baseline hypertension so they don't faint.
Okay.
Hi, I have a question.
Yes.
Dr. Rabakis. Yeah, I was wondering if you've ever encountered patients with orthostasis and maybe their blood pressure runs a little bit low, maybe they have Parkinson's disease, who just complain of being dizzy all the time or woozy or foggy. And it doesn't seem to correlate with their stand, like it may get worse when they stand up, but they're just dizzy all the time, even when their blood pressure is near normal when they're sitting.
Yep, exactly. And that's really what I was mentioning before. You know, we have a very clear sense of what dizzy means, what lightheadedness means, but the patient uses that interchangeably. And dizziness is probably one of the most common complaints of the elderly, and is multifactorial. Particularly patients with Parkinson will have their sense of imbalance because of their postural instability that will add to the problem. They may have degenerative arthritis in the neck, so the sensors in the neck that control the vestibular reticular system are altered, and so there is a mismatch in the signal. So the patient may move the neck and they feel totally like they're falling, because again, the signal is not processed properly. And so maybe all of the above could be a component of the persistent postural perceptual dizziness, can be a little bit of the blood pressure instability, could be the postural instability that adds on top, could be really any combination of that. So very difficult to sometimes sort things out. Those are patients that I think really do best if they work with a therapist, with physical therapy to a good degree.
Thank you.
Do we have any more questions from the audience? Let's see. Okay, I think, Dr. Sandroni, this is all the questions so far from the audience. I think it was a very wonderful lecture, really good discussion. We thank you so much for having the time to share with us all this very important topic that we always been consulted for it.
And if you have any additional questions that pop up in the future, just ship in my way. And well, good luck with your career. Think about the Autonomic Fellowship and have a nice weekend.
Thank you so much. Bye-bye.
Bye-bye.